With an internal exam, you can differentiate between the 3 different layers of the pelvic floor. So you've got 3 different layers that have a bunch of different muscles per layer. Innermost layer is going to be most supportive to the pelvic organs, and the outermost layer is going to be more supportive or play a larger role with things like sexual dysfunction.
Welcome back to the True Sports Physical Therapy Podcast. Today's guest, Dr. Mae Hughes, is a pelvic floor specialist. She did an amazing job at not just talking about pelvic floor in isolation, but bridging the gap between pelvic floor health and dealing with the elite level athlete. She's uniquely suited to do this because she was finishing her sports residency when she kind of had this aha moment that there's so much more to treat than just your sports rehab, but that we have to combine some of this pelvic floor health. You're going to learn in this episode, and I definitely learned a ton because I knew zero going in about pelvic floor health, that number one, it's not just for women, that men also suffer with pelvic floor dysfunction, and two, how closely linked it is to other pathologies like hamstring strains, hip flexor issues, low back pain, etc. Mae does a great job of really blending those worlds of sports and rehab performance with pelvic floor health. She was a pleasure to have. I think you guys are going to learn a ton. Mae got her doctorate from Belmont University after completing her undergraduate work at Vanderbilt. She then did her sports residency at Belmont and then found the pelvic floor health world. It was really a great conversation. I can't wait for your guys' feedback. Without further ado, here is Dr. Mae Hughes. Welcome back to the True Sports Physical Therapy Podcast. Our guest today is Dr. Mae Hughes. Now, off air, I had some choice words as to describing my level of knowledge of pelvic floor, but needless to say, I know zero about pelvic floor health. So I'm going to hopefully learn a ton here. This is going to be great value for all of our sports geeks out there because, correct me if I'm wrong, pelvic floor health is a big effing deal.
Absolutely. I mean, I worked with high-level athletes before transitioning to just pelvic floor, and honestly, I treat them basically the same.
Okay. I don't know. I think it's different home exercises, I think. Okay, so you're a sports residency trained PT. Mm-hmm. You're in sports residency. You're working with high-level athletes. You finish that and you start going down this world of pelvic floor health. What changed for you when making that decision?
It was mainly when I was working with higher-level female athletes. I mean, you develop really good rapport with your patients, especially with some of the college athletes I was working with, and they would eventually confide to me, hey, when I'm finishing this race, a lot of my track girls, they were unable to hold back from peeing their pants, or maybe in the middle of a run, or maybe during one of their workouts, if they were doing high-level jumping activities. And at that point, I knew briefly what they tell you in PT school, like the pelvic floor exists. Like, okay, so the pelvic floor is involved, but I was kind of like you. I know zero about it, and felt that if I wanted to continue working with high-level female athletes, that I really needed to learn more about the pelvic floor. So my patients wouldn't be peeing their pants at the end of a race. Like, it's great to have a PR, but if you can't hold back your urine.
Okay, so I get that. Now, correct me if I'm wrong. I'm decent with anatomy. It's not just female athletes that have pelvic floors. Everyone has a pelvic floor, right? Am I right about that?
Everyone. Okay. You are correct.
Okay, so you mentioned the female athlete. Tell me about how this applies to males.
Honestly, a lot of the same issues, but they have more, like they'll say generalized groin pain. So a lot of guys who have recurrent like hamstring or adductor strains, I tend to be consulted with for the pelvic floor a lot because of pelvic mechanics or just tension in general in the pelvic floor that might be leading to lack of use of their pelvic floor, which is causing compensations through their hamstrings and adductors. So they still have a lot of pelvic floor dysfunctions, but yeah, they're not necessarily peeing themselves like women are.
Okay. Good. Okay, that's one thing I learned, that pelvic floor issues does not just mean you're peeing yourself. It could mean other things. Okay. Mm-hmm. All right, so thanks for teaching me that. But I cut you off. So you're working in sports residency. This stuff starts to come up. You start to dive into the pelvic floor region. There are going to be so many puns here.
I know.
So you start to learn about pelvic floor dysfunction. Where do you go with that?
I started with two of the accrediting bodies. So Herman and Wallace is a big coursework place to find pelvic floor continuing education. And then APTA, they have basically Herman and Wallace and APTA have the two different paths of becoming almost like going through another residency of a certified women's health or pelvic health therapist. And that's kind of where I just started my training, going through pelvic floor 101, doing internal training, internal exams, which those labs are quite fun when no one knows what they are doing in there. You're all trying to figure out what are the muscles of the pelvic floor. But yeah, I thoroughly enjoyed it. I didn't think I ever would. I was full sports all the way. Obviously, I did residency, and I feel like it's only enhanced my ability to treat athletes.
Okay, so you finish that almost like a second residency, and then then your practice slowly becomes all things pelvic floor.
Yeah, it started about maybe only 75 or 75% were still my orthopedic sports patients, and about 25% were pelvic health. And it took about a year and a half for it to really become okay, I can make my entire schedule 100% pelvic health. I've still kept about 25% of just traditional sport and orthopedics. But of course, I'm still in the back of my brain always considering their pelvic floor. But I mean, like, the classic ACL repair or, Achilles, something like that. I like to keep on just a small little bit for things that I like to continue with that knowledge I spent so hard working on.
Yeah, you worked really hard and you probably spent a ton of money on it. So I can totally value that. So break it down for me as if I know nothing. Conveniently, I don't. So patients in front of you, what are some signs outside of, hey, Yoni, I'm peeing myself, that they have pelvic floor issues?
Luckily, so I mainly work with women. I don't do male internal exams. I will still consult with any of my colleagues who are like, hey, I've got this male that I think he's got pelvic floor dysfunction. What do you think? And I can still help in that sense. But just I personally don't do male internal exams. So women tend to be a little bit more proactive with their pelvic health. They will come in being like, hey, one, maybe I'm pregnant or early postpartum, or they've learned I have diastasis, like I have this bulge in my belly. I don't know what that is about. Maybe I've done some Googling and I know I need to see a pelvic floor PT, or I have a lot of heaviness during any sort of activity. It could be working out or just living life. Yeah, if they have pelvic heaviness, feeling like, a tampon is going to fall out. Honestly, a lot of women will come with that complaint. And so women are pretty proactive about reaching out for pelvic floor PT. The men, not so much, which I can understand.
What are the symptoms men are feeling?
Yeah, a lot of them, like I said, I don't see them initially. So a lot of when my colleagues would refer to me being like, hey, do you think the pelvic floor is involved? They might be experiencing, honestly, still urinary urgency. So they feel like they wake up 3-4 times in the middle of the night to go to the bathroom, or when they are going to the bathroom, maybe only a little bit is coming out, or erectile dysfunction. That's a huge complaint too. And those are all involving the pelvic floor, and a lot of posterior hip pain as well will involve the pelvic floor, and they just don't even realize it.
Okay, so that's helpful from describing some of the symptoms that your patient may be feeling. Then what do all the sports PTs listening? Then what the hell do we do?
I think the most basic thing that y'all can do, and everyone always rolls their eyes and laughs at me when I say this, but assessing their breathing in multiple positions is the easiest way to assess their pelvic floor without doing, an internal exam or, putting your hands right there at any insertion points, because the ability to get full 360-degree expansion of the rib cage, the lower back musculature, and still getting the belly and chest involved is foundational for pelvic health, because a lot of people have a hard time lengthening their pelvic floor. And when you inhale and your diaphragm descends, your pelvic floor should also descend too. So kind of what's going on with the diaphragm can give you a good idea of what's going on with the pelvic floor without having to directly assess the pelvic floor.
Okay. You said that assessing diaphragmatic breathing or what their diaphragm is doing can give you some sense of what's going on the pelvic floor. What are
Mhm.
you looking for with the diaphragm? How
You're
do you assess
looking, yeah, obviously you can't get your hands on the diaphragm, but because it's at the bottom of the rib cage, you can look for 360-degree rib cage expansion. And what you'll likely find is that people have a really hard time expanding posteriorly and laterally into that rib cage. They'll get a lot of anterior expansion, and they're having a really hard time getting into that lower back and the sides. And you can assess that even more. I kind of call this position like rock back breathing, where you're kind of almost like a little turtle. You're really trying to round that spine, the thoracic and lumbar spine, and see, do you even get any movement of the lumbar spine when they inhale? Because a lot of people have so much tension in that lower back that they can't even get that posterior expansion. Same thing around the thoracic spine. And that is a huge indicator that they're likely dealing with pelvic floor dysfunction, specifically tension in the back of that pelvic floor.
Okay. So I do that as a sports PT. I look at what the
Yeah.
diaphragm is doing. I did
Mhm.
not roll my eyes once at that, for the record.
Fantastic.
Yeah. So I've practiced. I practiced a lot. So then what do you do? I mean, what would you do as the pelvic floor specialist?
If someone was coming in with
Yeah,
like,
they have some complaints. You're worried about pelvic floor. Me as a
mhm,
sports PT, I'm looking at diaphragmatic breathing or what their diaphragm is doing, their
mhm.
ability to fill posteriorly, perhaps when they take a deep breath in, and then to contract on the exhale. What would you do next?
Honestly, depending on how comfortable you are, then I would try and walk them through what a pelvic floor contraction should feel like. Can you go from that lengthened state to that ascended state, that lifted state? And honestly, as professionals, we should have good enough rapport with our patients that we should be able to talk to them about the importance of the pelvic floor and its relationship to that deep core, the transverse abdominis, multifidi, what have you, obviously in better language that they understand. But we should be comfortable enough to be like, hey, this is just a part of your body that we need to make sure that you can properly contract these muscles. You can perform long endurance holds or quick contractions, and you can coach someone through all of that without having to do an internal exam. Because if they're engaging their deep core and you think they are, but they're actually not lifting from the bottom up, they might be squeezing their core canister out the bottom, if that makes sense. Like if you squeeze a soda can from the middle, the pressure is going to go somewhere. And if they're not able to counteract that pressure from going downwards out through their pelvic floor, then they're just putting a lot of pressure down on the pelvic floor, further exacerbating whatever symptoms they might be having. And so that lift is really important when they have that deep core contraction. And so I feel like everyone should be comfortable at least baseline cueing some sort of contraction.
Okay, so you're palpating their pelvic floor and you're looking for it to be doing what?
I mean, you can, like I said, depending on rapport, you can go the route of not palpating, depending on what your comfort level is. If you are comfortable with your patient, you can put your hand just externally, right outside of their pants, whatever they're wearing. And when they exhale and gently lift their pelvic floor up and in, you should feel a little bit of pressure move away from your hand, if that makes sense. So when they inhale, you should feel a little bit of pressure down into your hand, and then you should feel it lift up and away. And there shouldn't be any additional movement of like their glutes. There shouldn't be any pelvic motion. A lot of people think that just a posterior pelvic tilt or a glute squeeze is a pelvic floor contraction, but that is not it. And that's actually a sign of potential compensation. People will think that they're engaging their pelvic floor, but really they're just going to a posterior pelvic tilt or squeezing the heck out of their glutes.
Yeah. Okay. That makes a lot of sense. So if you're palpating for that, then I assume you teach them how to palpate themselves, and then that becomes some of their home exercise to try to reorient their breathing to contract the proper muscles at the given time. It's just like any injury. Um,
Exactly.
okay. Okay. So that makes sense to me. What the compensations that you would normally see look like? What they simply won't be pulling away from your hand,
Yeah. Or they're going
or everything
to,
gets contracted.
I feel like most of the time I see a lot of people just overly contracting everything else. So I also encourage all pelvic floor PTs or sports PTs to assess these things in multiple positions, not just laying flat on your back, because no one exists laying flat on their back. So I'll do these exams in standing and quadruped. Sometimes if they're only having symptoms with an overhead press, then I'm going to bring the weights into my room or wherever we are, and I'm going to have them perform the movements so I can see exactly what's happening, because you might hit to a certain threshold of weight that they're pressing overhead, and then all of a sudden they can't contain or manage that lift up and in anymore. But so I'd like to get people in all different types of positions. But other compensations that I'll see, like I said, is they'll squeeze everything. They'll squeeze their glutes, specifically going to a lot of hip external rotation, kind of gripping of the posterior pelvic floor. I'll see a lot of that posterior tilt as well. People think just kind of tucking underneath of you. And then I'll also see a lot of upper ab gripping. So a lot of people who crunch downwards from the rib cage down, they think they're engaging their core. Maybe that's the way they've always learned how to do crunches. But in fact, that's going to cause a lot of excessive pressure downwards because they're not lifting from the bottom up.
Yeah, I like you including some of the compensatory mechanisms of hip external rotation, because that makes me think you're putting yourself at an adverse position, and it would lead to the groin strains. It would lead to the chronic hamstring stuff if you're always trying to find external rotation or some compensatory mechanism to provide yourself stability. So thanks for explaining that. That makes a lot of sense. If that's like baseline, any sports PT can do that. What's that next level? What the hell's going on in an internal exam?
With an internal exam, you can differentiate between the 3 different layers of the pelvic floor. So you've got 3 different layers that have a bunch of different muscles per layer. Innermost layer is going to be most supportive to the pelvic organs, and the outermost layer is going to be more supportive or play a larger role with things like sexual dysfunction. So a lot of tension on the outermost layer is going to contribute to when people might complain to you of having like painful intercourse or those erectile dysfunctions. So that's where you can kind of tease out, okay, is it, innermost layer, outermost layer, and you can get more specific with the muscles that might be experiencing tension. So rather just, okay, let's get into that rock back breathing position and breathe into the butthole, what I'll have people do to get that cue to breathe into the pelvic floor. I can actually be more specific with my hand and be like, hey, are you experiencing tension, burning, any sort of uncomfortable sensation while I'm palpating this muscle? And then we can go through hip internal, external rotation, and you can actually get people moving around with their hips to see what point of that muscle or at what point that muscle is maybe more tight or having a harder time contracting. And specifically, with overhead exercises or standing exercises, I'll do an internal exam during some of those movements. With some of my women who like to lift really heavy weights, I can get a good idea, when they're doing an overhead press, at what point do they lose that ability to manage their pressure? And do I start to feel the sensation of them almost like pushing my finger out because they're bearing down so much? So you can just get a little bit more specific with the internal exam, which usually means you can get them better a little quicker because you're not kind of just guessing where the muscle is inflamed or which muscle is inflamed or which muscle is having a hard time contracting.
Okay. I'm going to pretend like that speech was normal. But you, in that speech, in that soliloquy, you use the term breathing into your butthole. So I think we should probably get back to that and explain what that means, because my head almost exploded when you said that. Then also, you're doing an internal exam while they're pressing overhead.
Yes, absolutely. You need to be able to know.
Mae, I am so thankful that there are pelvic floor therapists out there, because I would probably pass out if I was being
There's no way.
There's no way. It's crazy. Okay, so let's start with breathing into your butthole. What does that mean? Questions I never thought I would ask on a sports PT podcast.
Fantastic, though.
Yeah.
So glad we're bringing awareness to this. Yeah. So that's a really good cue that I will use for people who have a lot of tension in the posterior pelvic floor. So if they're having a hard time finding length in their glutes, maybe in that hinge pattern, if they're doing a deadlift and you feel like they're not getting enough pelvic expansion in that pelvic outlet, then getting them to breathe into their butthole is a good cue to find length around those muscles, because your pelvic floor muscles wrap around your anal sphincter, the vaginal opening, and the urethra for women, the 3 holes, versus obviously men, only 2 holes. So your that cue of breathing into your butthole, people really can identify with, okay, that's what it actually feels like to lengthen the back of my pelvic floor, because I can feel the air going in there. I can feel my, anal sphincter expanding. And so I'll even have people put their hand over their butthole. And when I'm telling them to inhale and find that good length, they're like, oh yeah, I can like feel a little bit of pressure when I inhale.
Mae, I can't wait for my buddies to listen to this pod and like just send me these clips of like, what do you do for a living? Like,
Oh.
who are you talking to? So I hope this is bringing awareness to someone out there, some sports
Oh yeah.
PT. Okay, so that's super helpful. And then, okay, so we talked about the internal exam, like when they're doing overhead presses or when they're doing anything athletic. What do you do with the runner? How do you mimic that?
Yeah, that one's a little bit harder because obviously I can't do an internal assessment while they are running.
You know what? You
Um,
never at this point, I would expect you to be able to do that internal exam if they're doing anything.
Maybe.
Yeah, okay.
We'll do a lot of single leg stance and like calf raises or single leg squats. So trying to mimic just single leg exercise for that internal exam to try and mimic as much as possible with running. But yeah, running is something. Running and jumping are a little bit more difficult. Although I've done some like landing mechanics, kind of where you're going, up into heel raise and landing real quickly. Not necessarily, off of a box or anything, but I have done that before.
Okay. Thank God for you. Now, I mean, as you're explaining these things, it's interesting to me as a sports PT because I definitely have patients who are athletes, obviously, and have pelvic floor dysfunction, and I will refer them to a sports specialist who does pelvic floor, or
Mhm.
vice versa. Um, how would a traditional pelvic floor PT who doesn't have your sports residency background? We have an outstanding pelvic floor expert. I should have had her on here with you, so I'm not just sitting here
Yeah.
blushing. Her name's Alexis Lynch. She's outstanding. How would someone who doesn't have the sports background be handling things like this? Would they struggle in that environment?
They definitely would, and I think that's why so many people brush off pelvic floor physical therapists, because the traditional way of learning pelvic floor physical therapy does not involve doing standing exams and jumping and
Yeah.
single limb stance and things like that. So a traditional pelvic floor physical therapist who doesn't have that sports background likely wouldn't do any of those things I'm doing. Maybe they would, get them into all fours on the table or side lying, but getting off the table and doing internal assessments likely isn't going to be happening. And the knowledge of different movement patterns is also going to be a little bit more limited. The full body approach to the pelvic floor that I take, and likely your colleague takes, is enhanced from our sports physical therapy knowledge. So that probably is where pelvic floor PTs kind of get a bad rep sometimes, of just do a couple Kegels and you're out the door and you're done, because I do
Yeah.
see that unfortunately still being done.
So I definitely saw that. I had a patient that struggled for a long time with these types of pathologies and symptomology, and we sent him to a pelvic floor therapist. This is before we had sports pelvic floor based
Mhm.
therapists, and they struggled a lot because there wasn't that carryover kind of from table to field or to
Mhm.
gym. So I could totally see where that comes into play. That's an awesome commercial for you, Mae. Like, it's such a unique specialty. It's really impressive. So I want to talk about the patient that I just referenced. He was coming out of a hip scope, and he had a
Mhm.
tremendous amount of pelvic floor symptoms post-op. So
Mhm.
why is that transpiring, and how do you address those?
Likely because of the interplay between the hip musculature and the pelvic floor. I mean, you have the deep external rotators. I can reach the obturator internus, which is not technically a pelvic floor muscle, it's more of a hip muscle. I can reach that from an internal standpoint. And so because of the interplay there, and likely scar tissue, even though it's a scope, you still get the development of scar tissue, and that can spread quickly to the pelvic floor. And so that's likely where that dysfunction, pelvic floor dysfunction, is coming from, simply because of, if he's had a hip scope and now all of a sudden recruitment is down of some of your larger hip external rotators. Now you're going to get the small obturator internist trying to compensate, and therefore you're going to be having more pelvic floor dysfunctions.
Okay, makes a lot of sense. So you talked about some of the. First of all, back to that patient. I always thought it was because of the post that they put in between the patient's legs, and they're distracting. Did I make that up? Is that a thing?
No, that is definitely plays a role too, right? You're messing with the actual integrity of the tissue and the mobility. So 100% that plays a role too. But just in general, a lot of hip surgeries that don't even have to be in that position do have a lot of pelvic floor dysfunction that is residual, simply because of, like I said, lack of ability to recruit different glute muscles, some of those deep rotators, and that scar tissue from even the smallest surgery.
Okay. Makes a lot of sense. Now, in my pea brain, like when I'm dealing with an ACL and you're trying to get a quad stronger, you add load.
Mm-hmm.
What do you do in this world if you're trying to get an internal obturator internist stronger? How do you add load? How do you get this muscle stronger if that is the case?
There is a fantastic article that I'll try and find and send your way, so maybe you can reference it on here. But they looked at EMG activity of the pelvic floor doing just a basic, pelvic floor contraction, a Kegel, and then a bunch of different exercises like a squat, even just like a cat-cow. I think there was an RDL on there, a reverse lunge. And the motor recruitment of the pelvic floor during all those exercises is a lot higher than just a regular pelvic floor contraction. So I add load the exact same way that you would for any other part of your body. So I will give someone just a heavier squat to do, but knowing how they are able to manage their pelvic floor under that load. So going back to that internal exam, we might start loading, 10, 20, 30, 40, whatever we're trying to get to while doing the internal exam to see at what point that failure is, go slightly below it, stay there for a little bit, reassess, go higher and higher. So I still load the exact same movement patterns, but I just have the ability to do an internal exam sometimes while loading those movement patterns.
Okay. Super interesting. That is fascinating. I'd love to see that article. If that's the way you add load and strengthen a given tissue, how do you increase range? Like, how do you stretch this thing? Is that the breathing stuff?
Yeah, a lot of it. So sometimes it'll be internal work to at least get them to understand what muscle we're even trying to approach.
Internal work by you.
Yes, by me.
Okay, you're doing the like soft tissue.
Exactly, soft tissue work, but just I have
no Graston tools. Yeah, no Graston tools.
No Graston tools.
Okay, but there is needling. We'll get into.
I was about to say there is dry needling. Yes.
Okay, so you're doing soft tissue, and then how do they take that home? They're doing the same thing?
Yeah, so depending on the intensity, if someone needs a lot of internal work, obviously I don't want them to become reliant on me forever. So there are tools one's called a pelvic wand, and it truly is like a silicone device that you can insert that kind of mimics my finger, and you can direct it to different muscles. Same thing where you can inhale, feel the lengthening, breathing into that point of tension from that pelvic wand while applying just a little bit of pressure to get the muscle to release, and then continue with whatever active mobility and strengthening work afterwards. So a lot of people who struggle with a lot of pelvic floor tension, I'll have them start that before their workout, maybe just do 5 minutes of the pelvic wand to get that mobility, and then go through their active exercises.
Okay, super interesting is one word to describe it. Dry needling.
Mm-hmm.
Mae, do you do that?
I have not gone through the certification yet of pelvic floor dry needling, so no need to be wary of me. However, I do think it is something that can be incredibly beneficial for the same reasons. It's just another tool in your toolbox as a sports PT. If someone's having a hard time truly connecting with that muscle or releasing tension, you can use it for either or. It plays the exact same role. And I've had it done on me, and it is not as uncomfortable as everyone probably is thinking it is. I'm able to dry needle. I'm certified in the full body. So if you can imagine some of the more uncomfortable ones, like your adductors or proximal hamstrings, that's about the same discomfort level. So it's not anything worse.
Okay. Is it a similar approach? Like, there's some people who use a pistoning technique. There's some people who use stim. Same thing applies.
Yep. Same thing applies.
Okay, that's terrifying, Mae. But I'm glad to hear that it doesn't hurt. I'm glad to hear.
I will say the stim work is usually not as common, at least where I have worked with colleagues for the pelvic floor, but it is more common when looking at like C-section scar tissue or lower abdominal work. The stim can be really helpful to help with that the recruitment of the lower transverse fibers that get so stiff and disconnected after things like a C-section.
Okay. Awesome. Let's dive into specific cases maybe that you've come across. So number one, I want to talk about when do you usually see this begin to present itself? I would guess in the female population, it's around pregnancy. That happens often. What is often, what do you commonly see in the male population? Like, oh, this person probably has some type of pelvic floor dysfunction.
I see it a lot when people are ramping up their load, whether they're increasing mileage as a distance runner, or for males specifically, or if they are just going through a progressive loading period, because there tends to be a lot of breath holding, like bracing, Valsalva maneuver, trying to lift that load, and that creates a lot of downward pressure on the pelvic floor. And then with those runners, a lot of them start to develop hip pain or hamstring pain, and that can lead to compensation from the pelvic floor, vice versa. So it's usually in males I see when they're ramping up their load or mileage in whatever form they're doing. Or honestly, after some sort of hip or lower back surgery. I do see that a lot because of just the interplay between those muscles.
Yeah.
But for females, yeah, pregnancy and postpartum unfortunately tends to set it off a lot. And then again, during like the menopause period.
Okay. You don't see it in younger adolescents.
I do, definitely, not as frequently.
Yeah.
But I mean, that's what got me into pelvic floor in the first place, is because I was working with these college-age women who were having pelvic floor dysfunction. But once again, I saw a lot in when women were loading up or increasing their mileage. Whenever there tends to be some sort of increase, I mean, that's what we see with all injury types.
Yep.
Whenever it seems to be some sort of increase in load, then that's when injuries tend to arise, unfortunately.
Yeah, I mean, but you're really making a solid case for pelvic floor dysfunction. It's really demystifying it. It's like, we know that injury occurs during X. We know that it happens in pregnancy. Like, we see it with low back pain, we see it with sciatica, we see it, right? So why not pelvic floor? Obviously, all the more so because of the way you're carrying your child.
Yep.
And then the same thing with load. Like, as we're increasing past our body's demands, we have these injuries. And so sometimes it's patellar tendonitis and sometimes it's pelvic floor. So don't be such a baby about it, is what you're telling me.
Exactly.
Okay.
Yes.
Okay. I'm trying not to be such a baby about it. Okay. Then patient walks in, they have some type of pelvic floor dysfunction. How long is a standard treatment course of care? Don't say it depends, Mae.
I know. That's why I'm trying to think in my brain. I will say, for the most part, pelvic floor dysfunction can be resolved, or at least graduated from pelvic floor BT and back to your regular sports physical therapist within 8 to 12 weeks. Now, I am able to work with people longer simply because of my sports background. So I'll get them through whatever pelvic floor dysfunction they're having, and then potentially continue on with them. But in terms of if you're truly just looking at the pelvic floor and you're like, I have someone to hand them off to, 8 to 12 weeks is usually enough to get someone back to baseline and then able to progress from there. Because at that point, they know the mechanics of, okay, when should I be lengthening my pelvic floor? When should I be contracting it? these are positions that increase tension. Okay, what movement patterns am I struggling to open up the pelvic outlet or the pelvic inlet? And from that point on, once you have that knowledge, you can just apply it to whatever exercise program or rehab program you're going through.
Yeah, yeah, that makes a lot of sense. You talk a lot in a lot of the content you put out. You talk about misconceptions as it pertains to pelvic floor. So tell me what some of those commonly held misconceptions are.
One of them definitely we just kind of touched on. Do you have to have had a child to have pelvic floor dysfunction? And the answer is 100% not. That's how I got into this in the first place. Is I was mystified that I was working with women who hadn't had children and were having pelvic floor dysfunction. So I think that's one of the biggest misconceptions, is that you had to have had children to have any sort of pelvic floor dysfunction, or that you have to be female to have pelvic floor dysfunction. People kind of forget about the males.
Yeah, yeah, we're so forgotten about. Okay, you also mentioned that it's just kind of like glossed over in our graduate programming. If you were creating a curriculum, where would you put in pelvic floor dysfunction and how would you address it?
I personally think it should be part of your orthopedics programming. So the same way, I mean, I don't know how every program does it, but we kind of go body part by body part. It goes low back, pelvis, and then, lower body, foot, and ankle. I think right within that pelvis or hip course or lecture series, you should have the pelvic floor series in there as well, because it's so important when looking at someone who's having chronic posterior hip pain, or anterior hip pain or low back pain. 9 times out of 10, that person also has some sort of pelvic floor dysfunction, even if it's not a large symptom like peeing their pants, but maybe they're having a hard time getting that lengthening of the pelvic floor that we just talked about. So they're living in a state of chronic tension, overuse of some of those hip external rotators, which is causing some of that nagging posterior hip pain.
Why do you think it's glossed over?
I think because originally pelvic floor physical therapists didn't have as much knowledge of the full body and how the pelvic floor played such a large role with how the full body works. And so because there used to be such a small lens of the pelvic floor, like I am just looking at the pelvic floor, I'm not looking at anything else related. It was glossed over because people thought all you could do to help the pelvic floor was Kegels, maybe some internal work, and move on, without recognizing the importance of core stability, the hinge patterns, hip internal external rotation. But I think as people like myself and people are kind of marrying their orthopedic and sports knowledge with the pelvic floor, it really is broadening people's horizons to, the pelvic floor actually does play a larger role in how the whole body works. It's not just Kegels.
I mean, it sounds like as if someone came in with anterior shoulder pain and you never talked about their scapula, right?
100%.
Everything attaches to this thing, so we should know how to control it. That's why, May, I wanted to have you on.
I'm so glad you did.
Yeah, I mean, it does. It seems essential. I will not be doing internal exams, but it just makes sense to kind of have that forethought. And hopefully that's what we're bringing to light, is that there is a piece that, especially if patients are struggling and just not seeming to get better, even if they don't have the incontinence or something directly tied to their pelvic floor, how big of a player pelvic floor health can be with a myriad of diagnoses and pathologies. It makes sense. Yeah. Okay. Can you share maybe a specific example of a patient that you saw struggling with a given pathology, not the incontinence issue or not the erectile dysfunction issue, that you were able to say, you know what, this is probably coming from their pelvic floor?
It was a female runner. She was pregnant, but also had a history of chronic hamstring strains. And she was continuing to run throughout pregnancy, and another hamstring strain came along, and she really had wanted to complete this marathon within, I think she was going to be 8 months pregnant when she was completing the marathon, which I'm pro for, whatever. If you can continue doing it, do it.
Yeah.
And she had worked with another regular physical therapist and felt like she would maybe go a couple months and then hamstring flare up would be back. And at that point, I know because of the attachment point, that proximal hamstring and that insertion point, it's directly on the pelvis and it shares some similar attachment points to the pelvic floor muscles. And because I also knew with her history of pregnancy that she was pregnant, just likely how impacted the pelvic floor was from that additional load of carrying her baby. And just the postural changes that occur during pregnancy kind of put the hamstrings at a bit of a deficit to be able to work there. And people get into more of like an anterior pelvic tilt, kind of thrusting the belly out forward. And so she thought she wasn't gonna be able to complete her running and have to stop running her entire pregnancy. But we were able to get her through her entire marathon. And then she went on to have a second pregnancy without any hamstring issues whatsoever, because of just the foundational knowledge. I didn't see her for that second pregnancy, but just from that foundational knowledge of her pelvic floor, she was able to continue on without any issues during her second pregnancy. But yeah, chronic hamstring strain, I believe it was, she may be around 3 or 4 months when I first saw her, and we got her all the way to the finish line.
All the way through it. Yeah. That's pretty amazing. It just gives me, it just brings back like a tremendous amount of cases where I'm like, oh, I probably should have entertained that as a leading cause or a driver in their pain. So thanks for sharing that. I think that makes a lot of sense. Okay, last but not least, if every sports PT changed one thing tomorrow to better support pelvic floor health in their patients, what would you say that is?
I still am going to go back to that foundational 360-degree breathing. I know you're doing it, but I still see so many physical therapists out there that aren't getting patients into a variety of different positions to assess how well they're getting rib cage, posterior, lateral expansion. They'll kind of look at the belly and chest and look for any compensations in that aspect, but kind of miss the whole back body, and specifically the ability to lengthen through the glutes as well. Can you get that femur to slide back posteriorly? Because a lot of people who struggle with pelvic floor dysfunction, that femur rides closer to the anterior portion of the acetabulum, so you're not getting that good slide and glide backwards into that back of the pelvis.
Well, I think a lot of that comes from, at least the way I was educated, was it's all about this transversus abdominis and palpating the transversus abdominis. And like there wasn't even a discussion of diaphragm mechanics and like how to assess that, let alone being able to brace in these various positions. So I think your point is well made that there's so much that we are missing if we're not looking at the way a patient breathes, but also the way they brace in different positions. And after all, like I talk a ton on this pod about the difference between an orthopedic physical therapist and a sports physical therapist. And I think that is the number one difference, is being able to assess normal mechanics in a variety of motions, right? A variety of planes. And you're making the same point, I think, with pelvic floor.
Yes, and that is something that a lot of pelvic floor PTs will miss. They'll keep them in one plane of motion. But as athletes, you're never in one plane of motion. You're constantly moving. So that's why I strongly emphasize, for those who are able, get them up and moving, standing, rotational, whatever the movement is they're experiencing dysfunction, that needs to be where you are assessing them.
Yeah. Okay. Fascinating. So thanks for demystifying that. I want to finish with a lightning round, Mae Hughes. You ready?
I'm ready.
Okay. God forbid, in the middle of your third pregnancy, you had pelvic floor dysfunction. Who is treating that? Who do you go to?
I'm going to one of my pelvic floor PT colleagues, 100%. I got one on speed dial and she's ready to go at any given moment. I don't ever try and just treat myself without having someone take an outside look.
Outside of Mae Hughes, give me a specific name. Who is the pelvic floor guru in the country?
Oh, in the country or in Nashville, Tennessee?
Country. We can't all live in Nashville.
Country. Nicole Cozine or Sarah Duvall. It's a tie between the two of them. Sorry, I can't choose one.
Okay.
Nicole Cozine or Sarah Duvall. Either of those.
Okay, I got to have them on the pod, although I've asked you all of my pelvic floor questions, so I'll have to come on with more. Okay, next question. Where where did you get your growth mindset? Because it is clear that you were going down one path, the traditional sports path, sports residency, and you had an epiphany like, hey, there is something more to learn here. I'm going to pivot a little bit and then combine them. That is a true hallmark of having a growth mindset. Where did you get that from?
I think I just like not being wrong about information or just knowing how to completely treat someone. I felt incomplete. That's truly what it was. I felt incomplete. And if I wanted to be a great sports physical therapist, I didn't feel, at least working with my female patients, I didn't feel like I could do so when I was working with these women having pelvic floor dysfunction.
I mean, is there a like seminal book that you read? Was there an influence in your life that made you think like, hey, I always got to be learning. This is what makes me Mae Hughes?
I can't think of a specific pivotal moment. I mean, I grew up in a very competitive, unfortunately, household. I'm the youngest of 4. And so I think I've always kind of had to prove myself in terms of my siblings, not in a bad way, but in a way that, hey, I'm not just the youngest sibling, like I can prove myself. And so I think probably having the youngest child mindset of trying to prove yourself maybe led to that.
You got a little chip on your shoulder. I appreciate it.
Yeah.
Mae, you are a wealth of knowledge. Thank you for demystifying the pelvic floor. You taught me a ton today, and I really appreciate it. Tell all of our listeners where they can consume more of your content.
drmayhughes.com is going to be where you can find all the information. You can find free blog posts. You can access my social medias from there. I'm on, classic Instagram, YouTube, trying to give as much information to people as possible to demystify the pelvic floor. Because when I have these conversations with people of what I'm actually doing during a pelvic floor assessment, they are just mind blown. So
they're mortified.
Mortified, mind blown. There's usually a bit of blushing, turning away from the camera, that sort of thing. There's no such thing as TMI. But yeah, Dr. Mae Hughes, DRMAE Hughes. And that's where you can find all the things for me.
Awesome. Guys, thank you so much for listening. Mae, thank you for joining us. As always, let us know what you loved. Let us know what you hated. Also, we are looking for an outstanding sports physical therapist. We have about 4 openings throughout our entire company. It's because we're growing like crazy. If you love pelvic floor and elite level athletes, we got a place for you. If you just love treating ACLs and elite level athletes, we are the place for you. So look us up, True Sports PT on Instagram. Let us know what you love. Let us know what you hated. Thank you so much for listening.